Association, the North Dakota County Social Service Directors Association, let's see what other ones, North Dakota Department of Health. The last two that I have left, so I was going to present previously, I think it was in January, February, but either Kathy or I were sick over a number of months. So I have public instruction and then the North Dakota Bar Association left, and then I did community presentations online for Minot and for Bismarck. And so what we're trying to do is get this information out to our partners all over the state, whether they're community partners or professional partners, and get feedback so we can make sure and ensure that the information that we're returning to our federal project officers, or specifically Department of Human Services federal project officers, is good information that we can enact to prevent it across North Dakota. So, let's go. Okay, so what I'm doing is part of the Families First Prevention Services Act. So we have to develop a statewide plan to prevent child abuse and neglect fatalities. So what's been going on is the Child Fatality Review Panel has collected demographic and death data for the past 10 years. Now I'm at the partner stage, and from that, we're going to bring back information to our federal project officers and to the Department of Human Services and see how we can enact that with our partners across the state. So they get the information from several data sources, the NCAND's, Vital Records, Medical Examiner's Office. So for something important to point out for NCAND specifically is the individual who abused and or neglected the child must be a person responsible for the child's welfare. So that's one thing to note that I've seen in this presentation. And then another thing to note is Medical Examiner's Office. A medical examiner is in a position to identify cases that may have been screened out or never reported to Child Protection Services, or that vital records missed by chance. So that's another thing to note within this presentation. And also, I'll make sure that I have the PDF to Kylie when I'm done presenting so everyone can review it. But these are some of the things to note from this slide. So the North Dakota Child Fatality Review Panel is does anyone or is anyone on this call or this webinar serve on the North Dakota Child Fatality Review Panel?
Yes, I do. Melissa Seibel.
Okay, okay, great. So, and I do not, I'm primary prevention, but I was just kind of curious. So they identify the cause of children's deaths. They identify circumstances that contribute to children's deaths, and they recommend change in policy, practices, and law to prevent child deaths. So that's what the Child Fatality Review Panel does. So they do in-depth reviews, case reviews, and here are some of the items that they consider. So child has current or prior Child Protection Services involvement, which is a strong predictor. Child was in custody of the Department of Human Services. Manner of death is natural, however, the child's death was sudden, unexpected, or unexplained. So the Federal Child Abuse Prevention and Treatment Act, the CAPTA Act, requires that specific information about child fatalities caused by or the result of abuse or neglect be reported. So the annual report published by the North Dakota Child Fatality Review Panel involving child abuse and neglect deaths and near deaths must include the following items: the cause and circumstances, age and gender, information describing any previous child abuse and neglect reports, the result of the assessments, and the services provided. And you'll see this data as we move along. So North Dakota's picture. 31 children died as a result of child abuse and neglect in the past for the 10 years of 2008 to 2018. Okay. So how many North Dakota children die each year from child abuse and neglect? So the purple is both. Neglect is, I don't know, blue-green, and abuse is blue. I can never exactly figure these two colors out. I should have looked that up. So as you see, let's go back. Let's see here. Okay, sorry about that. Okay. So 2018, you're seeing a higher amount of both neglect and abuse. And then in 2018 specifically, it's 5 children died of abuse, 3 of neglect, and 2 from both, so 10. We go down 17, had 2 from neglect. 2009 had 2 from abuse, 3 from neglect, 5 total. So that's the last 10 years. Child abuse and neglect determinations. So these are a few things that when I've served on committees with physicians and social workers, these are some of the things that they talk about. So fact-finding process. So Child Protection Services assessment is a fact-finding process designed to provide information that enables a determination to be made. And then the preponderance of evidence is a standard of proof in which the facts alleged more than likely than not occurred. So this is at times referred to as 51% standard. So, and that's needed in order to confirm abuse and neglect. Child demographics. So 13 female children, 18 male children at 58%. There's a breakdown of race with Caucasian, Indigenous, American Indian, African American, and other. And one thing to note, that 1 in 10 children in North Dakota were American Indian. However, 29% of the child abuse and neglect fatalities were American Indian children, so that's an overrepresentation of this population. So what age are children most vulnerable? I'm sure to no one's surprise on this phone, it's under 1 year of age. So younger than 1 for child abuse and neglect fatalities was 71%. And then when you're looking at infants, it's at 1 to 3 months is the highest percentage, which again, that is a newborn, and you're thinking about protective factors versus family stressors or caregiver stressors, and how that impacts the health and well-being of that newborn. So of course, young children are most vulnerable because of their dependency, small size, inability to defend themselves. So child risk factors: premature birth, substance-exposed newborns, disability, chronic illness, residing in a household with unrelated adults, and previous child protection services involvement. I'm sure not a surprise to everyone attending. So the largest predictor of injury and death and risk is a prior child protection services assessment, regardless of the assessment finding. And then 48% of the North Dakota child abuse and neglect fatalities were families known to the Child Protection Services program. So how did the children die? 19 were homicide, 6 were accident, and 6 were undetermined. And here's the breakout of those numbers. So for homicide, 65% with blunt force head trauma, gunshot wounds, starvation, asphyxia, accident, drowning, gunshot wound, unsafe infant sleep. Undetermined was unsafe sleep, neonatal drowning, substance-exposed newborn, and poisoning. So an infant's blunt head trauma, unsafe sleep, drowning, neonatal starvation, malnutrition. Abusive head trauma. So children range in ages from 2 months to 2 years. 75% were under 1 year of age. Caregiver often described the infant as fussy, and caregiver unable to manage caregiving demands. And there's a risk factor of lack of quality childcare. So filicide, the act in which parents kill their child or children, so that's anywhere from acutely psychotic to spousal revenge filicide. Altruistic filicide, the one thing that I have thought of with that one is, I don't know if anyone has seen the news, and it was several months ago, but there was a mother in Idaho who had joined a form of cult, the NDAAP cult, and her children have disappeared and they cannot find the children. I think the mom had fled to Kauai, but maybe she's back on mainland, but basically feeling like she's going to help their suffering by harming them because the end of the world is coming. So there's, you know, all these ranges of when parents or caregivers act this way. Unsafe infant sleep. So here are some of the stories behind that. So 1-month-old died of asphyxia, intoxicated caregiver on couch. 11-month-old in plastic bag in the sleeping area. So a lot of education can be done in this area as far as primary prevention and thinking through how we reach different caregivers and families. I remember my third child, we were visiting my husband's family in Mobridge, and I was breastfeeding, and she was, you know, probably under 6 months. And we didn't have a crib with us for some reason, I don't know. And I had taken a nap, breastfed and taken a nap, and I woke up a little bit later and the pillow had shifted, that it was kind of a little bit more over her face. And I will never forget that day, because never again did I sort of kind of co-sleep, co-nap. I always made sure that I changed those habits. So it's just something that we can think of from any range from of caregivers. That knowledge is super important. Okay, caregiver neglect, inadequate supervision. 15-year-old died of gunshot wound to the head. Drowning, chronic starvation. A 13-year-old died of chronic starvation. So neonaticide, labored and birth alone. Unmet mental health needs, concealed pregnancy, no prenatal care. Who are the perpetrators? So parents were the primary perpetrators of fatal child abuse and neglect at 80%, and non-parent caregivers were subjects in 11. Something to note for the non-parent caregivers, it's parental significant other at 57%, child care provider, unlicensed adult family member. So when you're looking at the parents who were the perpetrators, mother, 45%, father, 32%, parents together, 23%. Demographics. Well, I got that broken out. So for age, you have 18 to 25, 39%, so 13. 26 to 35 at 42%, so 14, and 36 to 45 at 18% at 6. And then the race. So what's happened since these acts with criminal charges? Murder, 55% sentencing, negligent homicide, child abuse and neglect, 22%. So 58% of the 33 known perpetrators of child abuse and neglect, maltreatment, fatalities were criminally charged. And then as of June 1st, 2019, 5 cases remain open with prosecution. And you can see the sentencing. The highest is 43% at 21 years and over, 3 to 10 years at 21%, and 0 to 2 at 36%. And the 21 years and over, there were 6 of them. So caregiver risk factors. These are the stressors. These are the things that predict it. So being young and having young children, unmarried, domestic violence, public assistance, recent major life event, substance abuse, unmet mental health diagnosis. I'm sure none of these surprise you. These are all challenges and stressors and risk factors. So child maltreatment fatality, 2 types, acute and chronic. So most often, 81%, the death-causing incident was acute, with either physical or physical abuse or physical neglect. And for 19% of the children, their death was chronic, with 68% abuse and 32% neglect. But the death-causing event occurred over time. Where do these events occur, these fatalities? So 48 and 52 east-west. So 61% took place in urban cities and 39 in rural, and then 13% occurred within a tribal jurisdiction. Prevention. So this is the part that is my favorite part, is talking about this. And then, you know, as we're going through this, there are some areas that the fatality review panel has already identified, and they have selected strategies to address primary and secondary prevention with attention to safe sleep practices, support for substance-exposed newborns and their caregivers, and building protective factors for families with infants and young children. So that is some of what they've chosen to focus on, but the point of presenting to partners across the state is to collect your viewpoint, your opinion, your input, and try to put this into our plan. So, old saying, it takes a village. So to address fatal child maltreatment, we need to provide support and education to parents and caregivers on child development, understanding that, selecting appropriate caregivers, safety education, and then community supports for substance abuse, domestic violence, and mental health. Strategies to improve systems and prevent maltreatment across the span of child safety and child family well-being. So you have child safety and protection, primary and secondary prevention, and then other improvements. So for primary and secondary, it's family support, treatment programs, services, evidence-based interventions, and then they'll have recommendations for investigation systems as we go through this. So here are the recommendations from the Child Fatality Review Panel. Uniform statewide reporting of sudden and unexpected child deaths. Continue to train and educate the medical field on timely notification to child protection services when a child presents with trauma and where child abuse or neglect may reasonably be suspected. Enhance community education of child abuse and neglect. Encourage ongoing education and training to all mandated reports of child abuse and neglect. Consistent application of law, and encourage comprehensive assessments and provisions. Background checks when placing a child in kinship or foster care. Education for parents about when to call emergency medical services. Establishing standards for lifeguard to swimmer ratios and pool safety needs. And then public awareness for drowning risks. Primary, secondary prevention. So statewide home visiting services. We do have home visiting services across the state. It could be more comprehensive. There could be more. It's not in every community or even region. We're getting a little further amongst the partners though. Safe sleep information. Making sure that different people and different avenues are talking to families about that. I connected the Mandan and Bismarck PD, and they're going to work with the Department of Health to train the police officers that when they show up at a home for whatever reason, that if they know the parents need a safe sleep option for their infant, that they'll have cribs on hand, and we'll be able to educate those parents. So it's just trying to think of different ways we can get that information and repeatedly to parents, so they know the importance of safe sleep. Quality preconception care, prenatal care, postpartum care, home medical support services, Dissemination of period of purple crying. Prevent Child Abuse North Dakota disseminates period of purple crying to all birthing hospitals, and we've reached out now to the Human Service Center zones. And I've had a request now with Watford City. They have some child care centers there that they would like to have that available in case there are families in need. Children under age 5 and children with previous involvement with CPS should be prioritized for in-home services. And again, quality, affordable child care. Emphasis on quality and affordable. So, utilization and completion of sudden unexplained infant death investigation reporting with the family after the death of an infant. Complete and thorough death scene investigations that include doll reenactment. And then address the lack of data regarding child maltreatment within tribal jurisdictions and data sharing. And that one will take time. I think that was important for the state and partners to understand, working with sovereign nations and the importance of how we approach partnerships with data sharing so the data is utilized appropriately and that there's a benefit to that sovereign nation with systemic change. Okay, what can you do? So this is the part, this other part that I really enjoy is I love hearing different ideas from the partners on what they think would help assist with prevention, whether it's primary or secondary or early intervention. And so one of two things. One, I can take notes and then make sure these ideas get into the plan, but also when I send the presentation, I'll have my contact information. A lot of people have been emailing me after they've thought about it for a while, but in addition, we are sending out, we just finished our Survey Monkey. We just did our final edits, and we will send out a Survey Monkey too, because a lot of times people just have to think about it because, you know, they've heard information like this, but you know, it's up to the group as a whole on what they would like to do moving forward. So here we go. I think that's it. Yep. I'm gonna stop there. Okay. I feel like I stopped the share and we're back to just visiting. All right, so what questions do you have, comments? How would you like to move forward, Dr. Anderson and everyone else on the call or webinar?
Yeah, thank you, Sandy, for presenting that. This is one of my least favorite topics to discuss, and something, you know, that is pediatricians, probably for most of us on this call, not the reason that we went into pediatrics, but it is an opportunity for us to make a difference and to help identify these children early. So, I mean, if anybody wants to pipe in on experiences that they've had or experiences that have been difficult, you know, one of the things that jumps out to me when we talk about referral to CPS, or, you know, there have been patients that are referred, evaluated, and then are bouncing in and out, and it's unclear to me how they're being monitored. And it seems like there's really a high turnover there, so it's very difficult to establish a relationship, you know, with social workers that are working in CPS. I don't know if that at all. It seems like the process is good, but the actual the functionality of the process might have.
I agree. I think just from the outside, I'm not a social worker. I'm a sociologist, so I really. Whatever, sociologist. So I don't have a practical application for social work necessarily, but from a systems perspective, I see a lot of tension with that. That's why I noted that, because I feel like one of the doctors on here was on the substance exposed newborn task force or attended those, but I did see some system tensions in those discussions, and I still do. I just don't know if it's how and we can solve that, but I definitely understand what you're saying there. Yeah. So that could be primary prevention, like as far as, you know, that system communication piece, but yeah.
Right. Anything else that, you know, I know this is a lot of information for us to take in. For many of us, we know the process, and we didn't really know the numbers, the more recent numbers. Any other questions or reflections that popped up? Otherwise, you know, we can definitely take time to reflect and get back in touch with Sandy and let her know what our thoughts are. Or if we don't feel as comfortable in this group forum, we can definitely, you can email me, you can email Sandy, and then we can make sure that that information is thoughtfully processed by the group.
Yeah, that's what most people have been doing. I receive a lot more after or informally. So the community forums, we've been serving food, which is a great way. You know, you sit down after and you go table to table, just really talk through some ideas. But you know, we're under a little different of a challenge here right now. So what I'll do is I'll send Kylie the PDF when I am off this call. And then the Survey Monkey should be out by either tomorrow afternoon or Monday morning. I'm waiting for one more person to take a look at that. And we're sending it to everyone that, again, that has attended, and people can feel free to fill that out and or email me or you with any information, and then we'll just put that into the report.
And then I have one last question. I know you started this process before COVID set in. Has there been any discussion within the group of alterations or heightened concern or changes in process as a result of restrictions that we currently have or related to COVID?
As far as child abuse and neglect concerns, or?
Well, as far as like how we implement, you know, a lot of what was discussed seemed like direct face-to-face programs that now we'll have to reconfigure.
Right. Not a lot. The only conversations I've had with the Department of Human Services specifically surrounding this is the concern of the additional stress, the isolation, and then children not having that opportunity to be in community settings, in their school, you know, preschool, Head Start, church, wherever one would gather. And then of course the domestic violence, you know, so just those increased rates, and then the inability to be exposed to mandated reporters to intervene if a family is in that position, and then be able to try to surround them with protective factors if at all possible. So that's been the extent of our discussion. I know specifically Lutheran Social Services has a great home visiting program, Healthy Families America, and PCAND has Nurse Family Partnership, and then also we administer Parents as Teachers up in Turtle Mountains. And we've moved everything virtually. So the home visitors are visiting the families virtually. And I know Healthy Families is doing the same thing. So I know a lot of these programs are switching to virtual. And I know from the Department of Public Instruction that a lot of what they're trying to do is make sure that the teachers are interacting, email, Zoom meetings with the children, and just different things. So there's different things that we've been discussing, but that's as formal as it's gotten because of how fast moving everything is going with the information.
And because one of the high risk factors was, it wasn't specifically listed as low socioeconomic status, but that's how I interpreted it. Have you seen that there's been any break in ability to communicate with certain groups? Or are we still able to Zoom, and with most families have smartphones or other devices that allow us to do that?
You know, I've just heard probably qualitatively or from just stories, not data, but there is a lot of concern about reaching families that are already under incredible stress and already, on paycheck or homeless. I know the Department of Human Services has been doing some work with trying to provide hotel rooms and different things to try to set up systems, because I think this has that COVID's kind of shown that, you know, we need to start strengthening our systems for children and families. And just from my own perspective, going downtown, and my office is downtown, and I haven't been there a lot, but I do have to go usually once a week so everyone can get paid. But I have great concerns about the homeless population, and who I know a majority of the homeless population downtown that are kind of the regulars by first name, and there's definitely been a detrimental impact to their health, their physical and mental health. And so, and that's just from my line of sight and who I interact with. And so I can't even imagine. And when it first broke out, I did hear from a family that we work with, and you know, PCAND is not a social service organization with primary prevention nonprofit, but we, you know, we're downtown, so we end up working with families. And I do know that initially there was a family with 4 kids that we connected with a group, and they got some help and a place to stay. And so, yes, I just from stories and what I'm hearing with the department and just the community, I think that I'm really concerned. Mm-hmm. So, and I know when we were both attended the webinar with Dr. Bruce Perry, and people are concerned about that as well on the call, and just, you know, him giving his perspective on that as well. But yeah, I'm concerned.
As far as, you know, for the physicians on the call now, if there are families that we are concerned about, mm-hmm. what is the best way for us to connect them with resources?
I would direct them to, if they have concerns, automatically go to their human service zones and talk to that, talk to that group. If they are seeing families where they're stressors, and they're 0 to 5, say, and they're stressors, but they don't feel like they've crossed that line necessarily, you can definitely connect them with PCAND or Lutheran Social Services. Lutheran Social Services has home visiting in Grand Forks, Fargo, Bismarck, Mandan, like we do, Dickinson, and Watford City. And then PCAND works in Turtle Mountains, Bismarck, Mandan, and going down into Sioux County. Okay. And so with Nurse Family Partnership, and there's Nurse Family Partnership in Cass and Clay County. So you could contact either one of our organizations who can connect you to the right people. Okay. Or contact your human service zone centers, and they will work with you. And also, I don't know, I'm sure you guys know about this, but there's parent resource centers across the state, and they're doing a lot of online programming now. And if, let me find the links. I do have a resource page that my program manager developed. I'll send that too, but that has all the parent resource centers across the state. They're doing a lot of programming online. And that's another resource for parents that could use that buffer that normally, and I would almost include myself in this, but that normally you can manage quite well, but with all of the stressors and tensions and just the uncertainty that, you know, maybe they just need a place to talk with other parents and get that support, kind of talk through some of their stressors, and then approach their family a little bit differently. You know, okay. So there's from any range, you know, because you're going to see all sorts of ranges. I remember I saw Dr. Toogood when my 3 older ones were little. They're like 5, I don't know, 5, 3, 2, 1, whatever. And I was in there an hour because he was late. And those kids were so ill-behaved. And when I left, he gave me some magic 1, 2, 3 book. You know, so I'm sure you guys see all ranges of families and all ranges of they think you're going to lose it kind of area. So I'll send those resources and take a look at them and pass them to your partners if you see value. But I think it's often overlooked, and we really could direct a lot of people to those. And those parent resource centers, directors are ready. They want to serve people.
Wonderful. I think those are great resources. So yeah, please do send over your slides so that we have your information so we can contact you. And then also if you could send over those resources just so that wherever we are across the state, if we identify families that need additional support that we don't have a high level of concern for, that we're able to hopefully connect them with resources, you know, before
it gets to that point. Right. Yeah. Exactly. So useful stuff. And at any time, if someone wants to, I'll leave, of course, my contact information. If you want to contact, I'll find whatever resource that is needed for whatever family. We might not be able to provide it, but we can connect you with that person that does. So.
That's great. Thank you so much, Sandy, for
Yeah.
coming with us, and then we'll follow up with you.
That sounds good. I'm surprised I made it through without the dog barking or my 12-year-old coming in.
Good work. Good work. Well,
All right,
thanks.
see you guys. Yeah, thank you. Have a good night. Bye.
Bye.
Thank you.
All right, guys. So we're just going to move on to the next part, and feel free, regarding Sandy's presentation, if there's anything that you guys have questions about or feel like you'd like to contribute to what the work group is doing, please feel free to email her, feel free to email me, and we'll make sure that it gets back to the work group so that they can consider what you're experiencing or what your ideas are in the plan that they make for the state. The next part of our meeting today is going to be about neonatal considerations in the time of COVID. I am so excited to welcome Dr. Karen Brown here. She's a neonatologist in Bismarck. She would not give me her bio to present her properly, so I'm going to piece it together as best I can. She went to med school at UND. She's from North Dakota. She did residency at Hawaii, which is also where I did residency. And then she went to Iowa to do her fellowship in neonatology and has been back in Bismarck for several years. I don't know how long. She's a great neonatologist. She has been wonderful to work with, a really incredible resource. I'm putting her on the spot tonight by asking her to talk about something that most of us don't know that much about. But it's a topic that we should all be getting on the same page, as much on the same page as we can with what we're experiencing across the state, and then we can open up the discussion on neonatal issues or anything else that we're experiencing as providers that are caring for children across North Dakota. So Dr. Brown, are you with us? There you are. Welcome, thank you for coming, and you feel free to start and we'll jump in with questions.
All right, good evening everyone. Kathy did ask me to present this topic, and I don't have a PowerPoint, but more of just a presentation and a discussion. But one of the things she wanted to talk about was basically the management and recommendations for the evaluation and care surrounding the perinatal treatment, the delivery, and the neonatal care of a PUI or a COVID positive mother. So there's a lot of information that blasts at us daily. One of the things that I did was just quickly look and review the CDC and the AAP guidelines and recommendations, and added in some clinical opinions because immediately there were clinical opinions that followed. So this is more, the AAP and the CDC tried for more evidence-based management of antenatal, intrapartum, and mainly the neonatal care. However, we have to realize that the recommendations are continually evolving. So the AAP initial guidelines came out on April 2nd, and they stated that the Academy of Pediatrics recommends that newborns born to mothers affected by or being tested for COVID-19 be temporarily separated from their mothers. It is also recommended that these infants be separated from newborns born to unaffected mothers in order to reduce the risk of transmission. This was very similar to the CDC recommendation, which came out, I think, at the end of March, and they too said that facilities should temporarily consider separating mothers who have confirmed COVID-19 or as a PUI from her baby until the mother's transmission based precautions are discontinued. Well, immediately experts jumped in and said that this recommendation to separate mothers and confirmed or suspected COVID positive cases after delivery is not supported by evidence, and this could cause lasting harm, I suppose, in regards to infant bonding, breastfeeding, issues like that. The World Health jumped in and they said that exactly opposite. They said mothers and infants should be enable to remain together, practice skin-to-skin contact, kangaroo care with mother, remain together, rooming in, especially immediately after birth during establishment of breastfeeding, whether they have suspected, probable, or confirmed COVID-19. So there's 3 varying views right there. And I think we'll talk a little bit about that. One of the things I wanted to talk about is in regards to the idea of perinatal transmission, and this whole idea still is unknown. There's very limited evidence, and there's uncertainty and controversy regarding actual vertical transmission. There's very minimal data due to the few numbers, but data from China showed that virus was not detected in maternal blood, in vaginal secretions, amniotic fluid, or breast milk when the virus was detected in maternal nasopharyngeal swabs. From China, there was 4 reports with 17 tested newborns that showed no evidence of vertical transmission. However, 2 additional reports showed that in 34 babies, 4 of the infants tested positive, thus suggesting vertical transmission. The symptoms range from mild to severe respiratory distress. 2 of those 4 had lethargy and fever, and 1 of the 4 had fever, lethargy, and vomiting. Pneumonia was diagnosed both clinically and radiographically in all of them. IgM has been detected in newborn infants. This indicates a primary infection with possible vertical transmission of the virus. Unknown variables in regards to the risk of transmission would be the severity of the maternal illness, the timing of the maternal illness in relation to delivery, the mode of delivery, vaginal versus cesarean section, and the duration of rupture of membranes. One discussion I saw regarding more of a neonatal COVID is very similar to our idea of early and late onset neonatal sepsis. Early onset was considered in the first week of life, and this would suggest vertical transmission. And one thing I thought was we should check neonatal IgM antibodies. Late onset was from 1 to 3 weeks after birth, and that would suggest either familial or nosocomial transmission, and with respiratory secretions or saliva. Some clinical symptoms include temperature instability, lethargy, respiratory distress, feeding intolerance or emesis. Lab work showed leukocytosis, lymphopenia, and thrombocytopenia, as well as nonspecific opacities on the chest X-ray. To diagnose COVID-19, suggest nasopharyngeal or throat swabs and or rectal swabs using PCR testing. So from what I found to date, there have been no reports of neonatal deaths. There's been a report of an infant death in China. I don't know the age. There's been a 6-week-old that was supposedly a death in the Chicago area. And I saw a 7-week-old in Connecticut in early April. Another thing to consider is the increased risk of preterm delivery remains unclear. One study suggested that there was a higher than expected incidence of preterm labor with preterm delivery. This, of course, goes along with the increased severity of the illness of the mother. If increased respiratory distress, intubation, the need for ECMO would lead to an earlier delivery. If the mother's COVID positive but asymptomatic, then the gestational maturation could continue. One thing I found on that, apparently on April 7th in Louisiana, a mother tested positive for COVID-19. She was extremely ill, placed on the ventilator. She went into preterm labor, and she delivered at 22 weeks gestation. That baby passed, and the state declared it, the state health officials stated it was COVID-19 was the cause of death, even though the cultures from the state or from the child remain pending. One of the things that the recommendations say is that all pregnant women with clinical signs and symptoms should undergo testing. So the PUI or confirmed case should be handled as per the CDC recommendations, but this is depending on the medical facility and the availability of resources. So they discuss the number of visitors and or support person needs to be clinically healthy or should not be allowed in the room or be their support person. There's a priority of testing of pregnant women who demonstrate symptoms on admission or develop symptoms during that admission. Currently, they recommend to separate the baby from the positive mother and then isolate from healthy infants. One thing just to jump in here, during the delivery, there's suggestion for droplet and contact precautions, gown, gloves, procedural mask, and/or eye protection with a face shield or goggles. That should be used for all deliveries and for all medical personnel taking care of COVID positive mothers and infants. If the infant or the baby is preterm and there's a risk of NICU admission, then you proceed to airborne contact and droplet precautions with gown, gloves, and an N95 mask or PAPR. And that should be used if the infant may require bag mask ventilation, intubation, tracheal suctioning, pretty much anything with an oxygen flow greater than 2 liters per minute for a NICU admission. The CDC changed their terminology pretty quickly and basically said that the maternal infant separation should be made on a case-by-case basis. And this needs to basically take into consideration the clinical condition of the mother. It needs to include the parents in regards to the decision-making. This has brought on increased maternal anxiety if the thought of separation from her baby. There's suggestion that separation, which I would assume interferes with maternal infant bonding, if the mother's planning on breastfeeding versus pumping with breast milk, that would be then fed by a healthy family member. And also consideration in regards to what the discharge plan would be. If a mother is extremely ill, then the plan would be to go home with a healthy family member. If the mother is healthy, no, if the mother is ill, the child would go home with a healthy family member. If she is clinically stable or asymptomatic, then the question is, does it make sense to separate the infant if you're going to send this infant home with this mother in 48 hours anyway? The parents have the right to refuse. They may decline or refuse separation. And then their suggestion in an attempt to decrease the risk of transmission by keeping the infant at a minimum of 6 feet away, or perhaps creating a barrier like with a curtain or something. The other thing is every medical center, their physical configuration is different. So not all medical centers have the space to separate moms, babies, and provide negative pressure rooms. So it seems like each medical center is actually adopting policies that best accommodate for their resources, the space available, and their hospital personnel. So in regards to the delivery room management, one of the things that's preferred is a negative pressure room with a limited number of providers in the room to limit the exposure to the staff as well. If there's a concern, additional providers can remain outside. One thing I read is that the NICU does not need to be present just because the mother is COVID positive. So you could have NICU standing outside and waiting, or if obviously it was a preterm baby, you had D-cells, you had indication to have the NICU assistance, that would be different. But they don't need to be there just because mother is COVID positive. The mother should wear a mask. And as I said before, all healthcare providers should wear PPE, including gown, gloves, and masks. If there's concern of aerosolized procedures, then you need to move to the PAPR or the N95. Suggested that the newborn stabilization occurs at a warmer, at a minimum of at least 6 feet away, and that healthy newborns be bathed as soon as possible. The parent should wear masks while handling the newborn. If the infant remains with the mother in the negative pressure room, then the infant should remain 6 feet away at all times, perhaps place in an isolette or create a physical barrier such as a curtain. Or the infant could be admitted to their own separate room if there's space available, staff available, And sometimes this may even be mother's wishes if she's extremely concerned or the mother is extremely ill. Right now, there has been no study to date that has demonstrated the presence of virus in breast milk. However, I did find that there has been antibodies to the SARS-CoV-2 that has been detected in breast milk. So there has been antibodies. In regards to breastfeeding or the infant remaining in the room, the mother will be asked to wear a mask. Breastfeeding or breast milk is encouraged. There are different ways to proceed with this. The breast milk could be expressed, followed with with the mother using a mask, a good appropriate breast and hand hygiene, and then the expressed breast milk can be fed by a healthy family member, and then thoroughly cleaning your pumping supplies afterwards. If the mother refuses, there needs to be a discussion. She needs to accept that there is an unknown risk of transfer. And once again, if she wants to breastfeed, providing washing hands and breasts and then breastfeeding. But once again, we don't know if there's a transmission or the actual risk. In regards to NICU admissions, they need to be admitted to a single patient room, preferably a negative pressure room. Once again, not all hospitals have that many available negative pressure rooms. If we don't have that many negative pressure rooms and it's more of a community type of a room, they state to maintain at least 6 feet apart and have the infants in isolates. One thing about breastfeeding, just a few things about the a couple agents I read in regards to antiviral therapy. Right now there's ongoing trials of remdesivir, and right now there's nothing known regarding the passage in breast milk. Now, apparently there's been some evaluation on hydroxychloroquine, and according to the package insert, shows no increased risk in birth defects during pregnancy, and also no reports of ill effects with breastfeeding. So in regards to newborns, after the baby's delivered, the optimal timing of newborn testing remains unknown. Most people are suggesting current recommendations testing at 24 hours of age and then repeating at 48 hours of age. In regards to supplies, lack of supplies or availability of supplies, using a throat and a nasopharyngeal swab and possibly a rectal swab, and then using PCR evaluation with a molecular assay. Discharges based on the medical center criteria. For if you have a positive neonatal infection, obviously if the infant is clinically healthy to go home, the infant should be followed up by telemedicine, telephone, or depending on what the pediatrician of their choice wishes. A healthy newborn can be discharged to home with a healthy, non-infected caregiver. If the mother is positive, she must remain 6 feet away, wearing a mask and appropriate hand washing at all times. Mom is considered negative when she's afebrile for 72 hours without any antipyretics. She has improving respiratory symptoms because apparently the cough may linger, and negative results of a molecular assay with 2 consecutive MP swabs collected at least 24 hours apart. That's kind of just a quick rundown of the things that are reviewed. So these recommendations are subject to change as additional evidence becomes available. And one last thing, just a general statement that in regards to, I think that the effect of coronavirus on pregnancy is something that we don't know right now, especially in the first trimester. We'll find that out in several months. The incidence of vertical transmission remains unknown. The risk of abnormal fetal development and neonatal outcomes are essentially unknown at this time, which I think we will see the results in the upcoming months and years. So that is just a quick rundown or presentation. I hope that's what you wanted, Kathy. Is there any questions that I can answer, or and maybe some of the Fargo colleagues can jump into? We fortunately I have not admitted any COVID positive babies to the NICU. We have had one I think it was just a PUI, COVID mother neonatal couplet. And so those are taken care of by our hospitalists. And Dr. Melissa Seibel was going to comment on her thoughts in regards to caring for that couplet. And if anyone has any questions or recommendations, suggestions, please feel free.
Thanks, Dr. Brown. That was a lot of information. And I think, I don't know, Melissa, if you want to jump in and talk about your experience with managing a PUI, or if we want to open up the discussion more broadly to how we potentially brace for more cases here in North Dakota, because it looks like it may be coming, and how we think to best manage these patients moving forward. Anybody that has any questions or any contributions, ideas?
Kathy, it's Missy, and I guess if there's no questions, I can jump in and just, we just had the one PUI, and so the mom was presumed positive and delivered. The second stage of labor is considered an aerosolizing procedure, so everybody in the room had to be in full PAPR garb for the delivery, and we kept our resuscitation team for the newborns kind of outside. Just because physically our rooms are too small to really accommodate all of that in the room very well. And our experience in discussing this with two parents, of moms that had to, were faced with kind of deciding separation or rooming in, is that mothers, as expected, strongly desire rooming in and are really averse to the idea of having immediate separation of the baby. And so we did separate just for the initial resuscitation, because that would potentially be higher risk of exposure to everybody, and then roomed in with the mom. And I think everything went really smoothly with that. It's, there's not, like Dr. Brown discussed, there's not a lot of data to strongly support any way that you go about it. So it's just a lot of conversations about kind of theoretical risk of exposure and kind of joint decision making. And so I think parents have been really receptive to that in our two instances that those discussions were needed to be had.
No, that's great. And I, on those weekly national AAP calls, a couple of things. They did discuss the AAP April 2nd document, and they really stressed how much of a working document it was, and they were very cognizant of the fact that their recommendations stated in that document were very conservative, especially given the severity of disease that we're not really seeing in this population. And so, those things were discussed explicitly, and they expect that since it's a working document, it will change over time, and the recommendations will change as we learn more. The other thing that was discussed, and I think part of the reason for the not rigid recommendations around this is that, yes, most moms want to be with their babies, regardless of whether or not they have infection, especially with something like this where we're not seeing significant severe disease in babies at this point. But nationally, what they've noticed is when there's a concern for maternal child separation, or the potential that a support person or spouse will not be able to be in the room, then moms are deciding to have babies at home, which is a much more concerning risk, obviously, for the patients that we're caring for both baby and for mom. And so in some states, they've noticed a rise in home births, and the risks associated with that, not just related to the acute birth, but the fact that then newborn screening is not done, hearing screening is not done. And so we have very limited follow-up or assessment of these babies afterward. Has anybody noticed any of that occurring within our state, any of those things yet?
Kathy, this is Missy here again. We haven't noticed that, but we did kind of preempt that, and as a facility have a kind of a handout and a discussion that will be part of routine prenatal care, so that mothers know kind of what would be expected during that time, know that they have a say in that discussion, and that everybody's opinion and health of both mom and baby would be considered, and we'd work with them on that so that they're not fearful of that. And so we're trying to kind of attack that on the front end with some really strong prenatal education to the moms.
That's excellent. Any other discussion, you guys? This is an important, anybody at any other, we just had 2 providers from the same birthing hospital. Anybody on this call from any other birthing hospitals? And, can you share with us what you guys are doing there?
I was going to say, we've definitely had a few more moms delivering at home. I'm not sure what the denominator is, but the N, the numerator of it was probably 3 in the last 2 weeks. So, and those are moms that came in because they had complications or the baby was sick. So I'm not exactly sure how many people are delivering at home, but it is a little bit scary, I think.
Yeah.
I also feel like there's a little more pressure to get the kids out early, and some of our late pretermers may be at risk for readmission.
Yeah. Yeah, so that has also been stressed. Thanks for bringing that up. Just the early discharges, and to make sure that we are ensuring that feeding is well established, and that the newborn screening and hearing screening has been completed at an appropriate time before we discharge. Any other questions or concerns? One of the things that did come up that Dr. Brown mentioned was the use of hydroxychloroquine for pregnant women and breastfeeding women. One of the things that was stressed on one of these calls, these national calls, was just that these medications are not approved for the use of children, in addition to not having strong evidence for their use for anyone. And so, ensuring that we're not prescribing these medications to any children that test positive or that we suspect are positive. Any other discussion regarding like how we're going to manage these babies or these moms? I know I had a close friend, I have a close friend who just delivered yesterday in New York, and a couple weeks ago there was the discussion of the possibility that partners were not going to be able to come in for labor. And some of the facilities were changing their policy to not allow partners to come in. And then they reversed that policy because they decided that, it is important that support people are available for, laboring mothers. But because of the high rates that they're seeing in New York right now, for inductions or C-sections for scheduled laborers, they're testing the day before, and then, so that staff is aware of how to manage the situation, and they're testing both the mother and the support person that's coming in with her. And then if it's a spontaneous labor, they're testing upon entry and assuming positive as far as, how healthcare workers gown and wear PPE until they have a negative result back. But obviously that's, a much higher incidence and prevalent population. So just something to think about if we would find ourselves in that similar situation. Everybody's quiet today. We had such a big discussion last time. Is there anything that wasn't on the agenda today that that people have questions about, or that we need to advocate for more, or resources that we need?
There is some talk in the hospitalist listserv about they call them COVID orphans. So we might get that eventually. That is, if both the parents are admitted, then there is a rise in social admissions for unrelated, like these are not sick kids, because foster homes are not taking place. In fact, in Evera Hospital in Sioux Falls, they had 110 COVID admissions, and out of which 2 are pediatric. So I don't have the exact details, but my brother-in-law is pediatric endocrinologist there. So like, and this discussion we had today. So like we are just curious to know like what are their age groups and what were their presentations.
Mhm.
But I'm just giving a heads up, like we might be flattening the curve in North Dakota, but we don't really know, like, will we ever have a surge, and if it does, when. Dr. Tiongson, did you have any pediatric admission?
We have, to my knowledge, we've not had any positive kiddos with COVID.
Because in that Smithfield outbreak, so there was all of them had Avera's insurance. So all of them had to go for admission to Avera, McKinnon Hospital. And they have 2 pediatric positive cases there. And I'll share with your group tomorrow because I just want to take his permission before I share. So.
And then, yeah, if you get his permission, share with all the rest of us too, Doctor.
Yeah, I tried calling him and he's like just not responding. So he must be working. So
yeah, I mean, I definitely
just
think
called him on this phone and it didn't go through. So. And there's an intensivist there, a pediatric intensivist. So I know him very well. So I also texted him before this meeting and he hasn't answered back.
Okay. Yeah, but please let us know once you find out. I definitely think, Smithfield has been all over the national news. It's in the New York Times, and it's one of the largest hotspots that we've seen in the country. And definitely when we look at what's going on in our state, we're definitely seeing surges on the eastern part of the state, and that sort of makes sense as far as, New York being the epicenter of our country, and then seeing the wave sort of go through Chicago and then sort of hit North and South, well, the eastern part of North and South Dakota. I honestly, it might be the New Yorker in me, but I honestly don't think that we have hit our peak yet. I don't think our social isolation has been saving us. I think that it just hasn't hit here yet, and that we're starting to see some surges related to that. So I do think it's important for us to continue communicating with each other and to be, prepared for, just like you say, Dr. Kumar, the COVID orphans that may be presenting if we have both parents that are taken into care. And to make sure that we are considering not just the care of our patients, but also the care of each other and our workforce, because we know that we're not protected from contracting this either. So
I just got a text from him.
yes.
So let me see if he is willing to talk to our group. He said, "Hi, Peggy." They call me Peggy. "We have 3 patients, 2 discharged. 1 was transferred to Omaha Children for complex heart disease with poor cardiac function."
Okay.
So,
Yeah.
do we need to talk to him or this is enough?
Well, I think it's enough information for now. And then if you can update our group, I think that would be really helpful with any of the highlights. And you can feel free to email us or, on our next call, we can definitely discuss that.
Yeah, we can have one of their pediatricians give us a talk,
Yeah. Are there any other questions or concerns, experiences that we've had?
Hi, Dr. Kingshuk. I just had a quick question. Good. Thank you. How many total patients in the hospital of COVID maximum? Like what's a good amount, total number?
I don't know the exact number, but I think there are 5 currently in the ICU and about 30 in the hospital.
Okay. Because I think at the peak, Ashu was mentioning they reached up to 110, but only 3 pediatric. Is that right?
Yep.
Okay.
We're not seeing nothing in pediatrics at all so far.
Okay. And you are like an intensivist, no? You are a pediatric intensivist there?
That is correct.
Yeah.
I'm admitting all the COVID patients.
Oh, so you are admitting all the COVID patients then. Good. So I was just wondering, like next week or next month, if you would be willing to talk to our group, like the Academy of Pediatrics North Dakota chapter, that what are the practical problems you are facing? How do you manage them? Are you having any COVID orphans? We would love to hear your input, and I will have Kathy Anderson connect with you. So is that something that you would like to share your best practices? Like, because we also don't have zero, we have 0. We have no newborns. We have no other patients at all. So Did you have pregnant moms delivering there with positive COVID?
But that's not that I'm aware of, because I'm the PICU and I do the hospitalist in the PICU.
Okay.
So I think I'm OB side, on the newborn side.
Okay.
At all.
Oh, so the neonatology group is managing the newborn side. So you are doing only.
Yeah, we don't do.
Okay.
That's the pediatricians and the NICU. I think the NICU is separate unit.
Thank you. I'll touch base with you. Actually, I was in the middle of a conference, so I will touch base with you. And thank you for calling back. I really appreciate you, King Shuk.
Yeah, but yeah, no problem. No problem.
Yep, I might just.
Yeah, I missed the call. I wasn't sure who was it. I get so many junk calls.
Yeah. No problem. Thank you.
Yeah.
Yeah, once they develop a little bit of, like, I'm sure they will have, this is actually the largest outbreak outside the Princess one from single source in the whole world.
Mm-hmm.
You know? So this is like I'm sure they will probably they have like whole CDC and the whole NIH and even the National Guard, like walking in the streets there, like trying samples from homes and trying to contain it, contact tracing, and anybody who remotely.
With everything that's going on at the meat processing plants, they're actually, the NIH and the CDC has gone out to many of these processing plants to look at how close the quarters are and what is predisposing many of them to these outbreaks. So that, you know, there are concerns for our food supply as well that we're going to have to consider. Thanks, Dr. Kumar.
Thank you.
Send me that information so that we can connect with him and have him help advise us on our next call.
Yeah, he's taking care of all the COVID patients. They have isolated their staff. So what they're following there, they call it half and half. So like if there are 2 intensivists, then one will work for 2 weeks and another will work for 2 weeks. So all the pediatric endocrinology, all the pediatrics department include every single doctor, whether in internal medicine or thing, is working on 2 week on, 2 week off. They're losing like $40 million a month. They are like bleeding like crazy. You know.
I know. Have any of your institutions discussed taking care of adult patients with you? Is that a concern or something that is already being done? And then has there been any, that's one of the things that was mentioned on the national calls, and then any renegotiations of contracts or decrease in pay that any of our physicians in the state have, any of our pediatricians have experienced?
This is Myra. Oh yeah.
Okay.
We took a cut last week and don't know what's going to happen from here out, but that's the whole system took a cut last week.
Okay. I think nationally, a lot of private practices were forced into closure. And so, you know, the AAP is advocating for channeling some of the funds that the government is providing for small businesses to go to, you know, physician practices and to pediatric practices. And so if any of those of you on the call have a private practice, you may be eligible for some of these funds, and just email me and I can connect you with some of those resources. They're also advocating for payer parity for telemedicine. And many providers have started to provide that. And so those are, I have a little one. So those are the things that I've heard on these calls that are happening nationally. And then pay cuts has been something else for people that are at larger institutions that pediatricians have been forced into some pay cuts, or have been offered the opportunity of furloughing, you know, if they have kids at home and they'd like to furlough and still receive benefits, have been given that opportunity as well. So if we're noticing this and it's something that we need to work together to advocate for pediatricians across the state, please let us know.
This is Patty Watkins, one of the neos at Sanford. We definitely got an email that said that we had the opportunity to collaborate with our colleagues and work outside of our normal scope of expertise, which to me sounds like they are looking for anyone who'd be willing to operate in the adult world, which is a little
Right.
scary.
And how do they, are there protections for you? Like as far as liability, are there protections in there?
There was no mention of protections. There was just mention of some sort of compensation and some degree of, I think they called it upskilling, but no mention of how the providers would be protected for operating outside of their scope.
So Patty, this is Missy. I think we work at the same institution, obviously. They have assured me that as of right now, there is no plan for that type of shift. They're looking at, for instance, like outpatient internal medicine physicians getting some extra kind of quick updates to manage more inpatient stuff on the hospitalist side, or hospital and adult hospitalists getting some crash courses on a little bit more complicated kind of respiratory management, but they are not at this time looking at the pediatric side, including intensivists, which I specifically asked, shifting to care for adults. I know that that varies by site because some other sites have heard differently with that, but there is some protection being written into the credentialing process and things like that, so that if there was an urgent need for somebody to intervene and assist, they would be supported by the administration in that practice.
Okay. This is something, actually, I don't think you guys were on the last call that we had in March, but Dr. Joan Connell, who is a past president of the North Dakota American Academy of Pediatrics, but she's currently a field officer, I think is her title, at the Department of Health. And so she discussed this question at our last meeting. And the question that she posed was, how would pediatricians feel if we reached capacity in the hospital and we had many of the beds filled with COVID patients? One, about shipping patients, pediatric patients out of state for care. And two, as a pediatric provider, providing care to adults. As a hospitalist or inpatient pediatric provider providing care for adults. So it was a question that was asked a month ago. She hasn't reconnected with us or asked us to add this to the agenda for this discussion. And I imagine it's going to just depend on how things pan out as far as numbers and capacity. But it was something that was broached at last month's meeting. So, I think with travel restrictions, and I don't know, workforce needs, and I don't know what percentage of our workforce for nurses and for physicians were locums or travel nurses. I just don't know how things might change if we are getting closer to capacity, because the Department of Health did pose a question like that a month ago for our meeting.
Yeah, I think everything is kind of dependent on that capacity issue. What they reassure us now might go completely out the window depending on the volumes. But I think, we've suggested that it would be reasonable to care for young adults with, there's not much difference between a 17, 18, 19, 20, 21, in my opinion. And so some of that I think we could readily cross.
Sounds good. Any other discussion? Any other concerns you guys have?
This is Carrie Random. I'm a pediatrician in Hettinger, North Dakota. I serve the Southwest Quarter. I go to a bunch of satellite clinics. I'm just curious as to what people are doing in the outpatient setting with well child exams and everything during this time currently. I see the well childs that need immunizations. Curious as to what other people are doing throughout the state.
Carrie, yes, I don't think I've met you before, so it's nice to meet you. I can tell you that what you're doing is in line with a lot of what's being done nationally. So the American Academy of Pediatrics put out a pretty clear recommendation that yes, we should continue to see children under 2 face-to-face and do our regular well checks with immunizations and keep them up to date on those immunizations. And then for children over that, they're just recommending holding on these well checks until we've started to see the peak decline. And, you know, as far as what practices are doing nationally, they are doing very similar to you, where they're doing morning wells and then afternoon sicks. I know that some practices in Bismarck are having well clinics, well only clinics, and then some sick clinics. I don't know, you guys pipe in.
I'm doing a lot of my well child checks by video, and it's hilarious in some ways, and in some ways it's the best ever, because I get to see the child in their home. I get to see them interacting with their other family members or their pets, or, you know, different things, and I get a whole new insight into how they normally operate. And I've learned a whole lot of stuff about some of these kids. You can't do a great exam, but you still get a really good sense of development. And I'm not missing out on a lot of teaching moments that I can have with the family, and especially when the child is running around the living room and I can see, oh, there's a danger we should talk about. You know, have you noticed this corner? Sorry, it's Myra Quanrid in Jamestown.
I knew your voice, Myra. One of the questions I have for that, you know, this well child, telemedical well childs has been discussed on the national calls, but only 3 states currently are reimbursing for it. And I think it's Washington, North Carolina, and Vermont or New Hampshire. How have you gotten approval from your insurers for reimbursement?
I just have them on my schedule when I see them. I haven't asked.
Okay.
So maybe I'm not going to get paid.
If they're on Medicaid, you should be receiving payment for it.
The 2 I saw today were Blue Cross, but
and I think Blue Cross too has approved everything
for well child care?
For all telehealth visits. I'll check with them tomorrow.
Yeah, I think that would be really really helpful. Right now, I wasn't aware that they were covering.
Kathy, this is Susan in Grand Forks. Yeah. All True Billing has said yes as well, and we have been doing well childs by video for those in between vaccination ages.
Okay, that's great. But nobody's received payment yet, huh? It's too early.
You know what? I can check and see, because we've actually been doing them for several weeks now. So I can check and see with our billing department what payment has looked like for you.
Yeah, let us know. Let us know. That would be really great to know. Anything else, you guys? That was a great question. All right. Well, I think, you know.
One thing, suppose we don't get paid, would NDAAP consider advocating for drive-through immunization clinic? My secretary, my clinical coordinator, Maxine, she had to go to help her daughter in Oregon, Portland, and there she described getting shots in the car. You know?
Oh yeah, I mean, they're doing it all over the country. They're doing shots in vehicles. It would depend on like workforce and really more it would depend on the institutional policy if they're comfortable with that. I think that there are states that are doing it. I don't know states that have their AAP advocating for it specifically, because it seems like it's really institutional dependent. But I think it's an option, and it is being done. People are using all kinds of creative ways to immunize. So.
Thank you.
Okay, well, thank you guys so much. It's the end of our meeting. If there's any additional questions or topics that we need to discuss, or you have ideas for speakers, or just ideas for topics and I can find the speakers, then please feel free to email me or email Kylie, and we will do our best to have timely topics and speakers up. I want to thank Dr. Brown for coming on and updating us on all the most current recommendations on neonatal COVID. And I really appreciate the time that you took to put all that together, because now I feel most up to date on what we know, even though there's a lot of unknowns still. And then, you know, for the first part of the meeting, if there's anything as far as the child maltreatment and the child death review that you have to send, feel free to send it to me, feel free to send it to Sandy Tibke as well. And I'll also will send out the resources that she sends over just in case we have families that are in need.
Yep, and those are also her presentation and a handout that she talked about. She's already emailed them, and I have them up on our website now,
Perfect.
so those are available.
You're so fast, Kylie. Thank you, Kylie, for setting this up for all of us. And just let us know, stay connected. Let us know if there are specific needs that you guys have, and we'll do the best we can to meet those needs. Thank you, guys.
Thank you. Good to talk to everybody.
Yeah, same here.